It's truly an honor to be among friends here. I was asked to talk about pediatric abdominal transplants, but having 45 minutes, I thought I'd first talk about kidney transplants, and if you like it, I'll come back for liver. So this depicts the skyline of MUSC, and hoping it'll change in the next few years. I'm sure you're all excited about this, so I particularly put this insertion into my first slide here. A couple of years ago, I received an endowed chair from the department, and Laura Phillips is one of our patients. Some of you may remember from a few years ago. It's always, you have to be nervous when someone is there as a surprise guest speaker for your talk, for your presentations. And Laura Phillips told the audience, I think of Dr. Baliga at least 4 times a day. It's every time I go to pee. So I didn't realize I had that reputation in the community for kidney transplants. I'm nervous about the reputation I'll have for liver transplant. So I thought this would be a good title or a motto for the kidney transplant program if Dr. Twombly approves it, that just like No Child Left Behind, that every child in South Carolina should be able to read, write, and pee. So coming to some more serious considerations here, this is my outline of my talk. I was going to give you a brief or kind of really a more detailed background, a selection of candidates, some surgical considerations, and a lot of emphasis on outcomes, and finally, leave you with some what's there in the future. So I think this is job security. So renal failure in this country continues to increase, and it really is skyrocketing. As you can see, this is all comers, adult and pediatric populations. And transplant, as you can see at the bottom of the graph there, cannot make up for the growing number of end-stage renal disease patients. The predominant increase is in the older population as we all get older, and it's driven by the increasing incidence of diabetes. Fortunately for us, the pediatric population has remained fairly flat over the course of the last several years. Racial disparities still exist, and if you pay attention to the bottom slide, the incidence in African Americans is almost 3 times the incidence in the white population. And this is particularly relevant to us living in South Carolina. We roughly have a 30% population of African Americans, but approximately 65% of patients on dialysis are of African American origin. And I don't think that's changing anytime. In children, the incidence has been fairly flat. It's about 15 per million. And it's across the board. This is across different USRDS regions. We belong to USRDS Network 6, and the incidence is approximately about 15 per million population. So I think this is an important consideration as we plan, what you have for end-stage renal disease programs in the state or for the New Children's Hospital. I think most people do not realize that end-stage renal disease is a lethal disease. This is all comers again. The mortality on dialysis as each year goes on is steady. So your 5-year mortality is almost 25%, is higher than some of the cancers that are seen today. So a kidney transplant offers a significant life year advantage. The life year gain is not as impressive at the extremes of life in the younger population or in the older population, but overarchingly, you would find that kidney transplant has a significant impact on life years gain, and this is frequently forgotten. There's a general misconception that kidney transplant improves, and it definitely does improve quality of life, and the emphasis appears to be quality of life, not necessarily life years gained. So in my talk today, I'm not going to emphasize any impact on quality of life and growth and development, and it's just, want to make sure that you take home the message of life years gained. Again, in the pediatric population, the highest mortality that you see is in the younger age group, the 0 to 9, and those patients on dialysis. And again, the patients on transplant have the lowest mortality. And I agree with you, this may be comparing apples and oranges because not everybody on dialysis is considered for transplant. But But there's several studies that have compared patients on the waiting list to patients who received a transplant because of the delay in getting transplanted. So if everybody qualifies for a transplant, in that group of patients, kidney transplant again has a significant impact in life years gained. In this current era, we always have to emphasize, and keep an eye on the economics and financial status. So this has end-stage renal disease has a huge impact on Medicare, and as you can see, this is in billions. We are currently at close to a 30 billion mark in terms of Medicare expenses for end-stage renal disease. Although transplant is a very expensive procedure, transplant is a very small number compared to the overarching cost of taking care of patients with end-stage renal disease. And the other take-home message here is transplant is cost-effective. If you have a kidney transplant which works for a couple of years, the first-year costs are actually higher than dialysis. Dialysis is approximately about $60,000 to $70,000 a year. The first year of kidney transplant is approximately about $100,000 to $125,000 a year. And after that, it's just maintenance cost. It's immunosuppressive drugs. And that cost can range anywhere to about $8,000 to $12,000 a year. So if a kidney transplant works for a couple of years, it becomes cost effective. And this again has been proven in multiple studies. So again, the take-home message here is life years gained and is cost effective. And those are very important considerations to consider for a kidney transplant. Brief, detour in history. The first kidney transplant here, in this country and throughout the world in 1954 between the Herrick brothers, and this was done. And Joseph Murray received the Nobel Prize for this in 1990. And the other members of the team, Hartwell Harrison was a urologist. David Hume was another transplant surgeon, unfortunately died in an air crash, and John Merrill was a nephrologist. I don't think they got IRB approval for removing that kidney in 1954. And this is 50 years later, Herrick and Joseph Murray, and this shows the safety of living donation in well-selected patients. At MUSC, the first kidney transplant was done by Dr. Charles Fitz. I don't know if many people in the audience would remember him, probably Dr. Tecklenburg and maybe Shashi Pai may remember him. He was a very impressive personality, I'll leave it at that. And the first cadaver kidney transplant was performed at MUSC in 1971. So in children, for selection of who are the candidates who qualify for being a kidney transplant, we have a simple rule, GFR less than 20 cc's, and there are different ways you can measure a GFR. And we really don't focus as much on the etiology of transplant, more than for a workup for what is required. For obstructive uropathy, I want to make sure the bladder is okay. We are very nervous about this disease, focal segmental glomerulosclerosis or FSGS, because of high incidence of almost 50% incidence of recurrence in many of our patients. And so these are some other indications in the pediatric population. It's completely different than what we see in the adults, where the predominant emphasis is diabetes and the workup of coronary artery disease. So the workup of children is completely different. We are required to have a multidisciplinary committee to review our selection process. And this is a Medicare requirement. We meet at least once a month to review our kidney transplant waiting list. And we have a transplant nephrologist, currently Dr. Twombly, our surgical team. There have to be a transplant-specific social worker, PharmD, dietitian, and nurse coordinators. These are the federal requirements with formal minutes, etc. So once you're selected for a transplant, what impacts your outcome? So I'm going to talk briefly about timing, the types of donors, a lot of misconceptions about HLA, and introduce a new concept, kidney donor risk index. So the timing of transplant is critical. Preemptive transplant do extremely well compared to patients who have been on dialysis for a couple of years. Now again, in the pediatric population, this impact doesn't seem to be as great, but as you can see, this is a 10-year survival of living donor transplant, a huge difference. So I think a pediatric group does an extremely, fantastic job and, tries to get patients referred to our program, way ahead of time. And so we always try to keep, ahead of the ball. But this is a very important concept compared to an old era where we felt patients had to go on dialysis. And sometimes, to be honest with you, we struggle with some of our teenage children when non-compliance is so high. And I feel that, perhaps if they understand what dialysis means, they'll appreciate transplant more and keep taking the medications. But that is, a pretty sadistic view on my part. On the other hand, there's a waiting time for cadaver kidneys, and this is MUSC. Again, for any of you who are interested, SRTR is our Scientific Transplant Registry. This is a public website, so unlike any other field in medicine, all our results are on a public website. So you can go to srtr.org and you can compare or look at any transplant program, UAB, MUSC, New York, Seattle, whichever program you're interested in. And the key factor here is waiting time. So on the cadaver waiting list, we approximately have a 2.5-year waiting time compared to the rest of the country, which has close to 4 to 5 years of waiting time. And this is a growing national controversy of how kidneys should be allocated. Fortunately for us in South Carolina, and it's still embarrassing for me that someone has to wait 3 years on dialysis on the cadaver list. The list favors children. I don't have time to go on the kidney allocation, but I'd be happy to answer questions. Children get extra points. The waiting time for children is almost half as it is in adults, usually about 6 months to a year for the children. Clearly a huge emphasis on living donor transplants. It's, because these are the best quality kidneys, and living donor kidney transplants almost have, more than a 20-year, 25-year survival rate compared to a deceased donor transplant, which is approximately about a half-life about 14 years. So this has again gotten controversial in children because the extra points that they're getting for a cadaver transplant. So nationally, again, this has become controversial. There are certain pediatric nephrologists who are encouraging cadaver donation and telling their parents to hold on to living donation when the child becomes an adult, so the child can receive a living donor transplant later in life as a second transplant instead of waiting 3 years on the adult transplant waiting list. Don't know if I'll agree with that, because I think upfront, if you have a kidney transplant, your success rate with and your impact on growth and development, etc., is so much better with a functioning kidney. Now, does histocompatibility matter? In the old days, we used to have huge arguments. If you had 3 donors, who can donate? Should the brother, sister, mother, who should donate? And currently, we don't give as much emphasis on histocompatibility. And as you can see, if you have a perfect or a 6 antigen match kidney, you can have a significant improvement in graft survival. But between a 5 antigen match and a 0 antigen match, the difference is not very significant. It's just, you can just say it's just a few years, but it's still, a couple of years between a 2 or 3 antigen match or, a 0 antigen match. So compared to the old days, not as much emphasis on histocompatibility. I think just, going to spend a little bit of time on histocompatibility because this happens behind the scenes, and I think it has a great impact on our results. We have now shifted to what's called a virtual cross-match. So for every kidney transplant, no kidney transplant goes to the operating room unless we make sure there's a cross-match which is negative. So the cross-match defines whether you have preformed antibodies, very much like your blood type. You can't transplant a blood type A into a B. You have preformed antibodies. Same way with histocompatibility. But what has occurred here is that you have what's called single antigen beads, which can define very specifically and with a great deal of sensitivity what your preformed antibodies are. So when you have very specific antibodies, then you can predict based on your donor antigens whether you can come up with a positive or negative cross-match. So we now bring in patients based on this virtual cross-match, which is currently about 95% accurate. So, and in fact, with patients with a 0 PRA or no antibodies in their bloodstream, if they have not been subjected to any infection in the month before transplant, we would go to the operating room without a real cross-match. The cross-match technique has also changed, and I'll bring this back to relevance later, to flow cytometry cross-match. It's a much more sensitive assay than the old assay, which was called a cytotoxic assay, and how you count the number of dead cells. So looking for preformed antibodies, you add, in the recipient, you take donor cells, you take donor lymph nodes or donor lymphocytes, and you add recipient serum in the presence of complement and look for cell lysis. The flow cytometry cross-match has become so sensitive that our current rejection rates are remarkably low. And I'll come to that in a few seconds. So this is again showing, what's called luminous assays or single antigen beads. And so HLA has become far more sophisticated. We don't see this up front when you are taking care of a patient in the ICU or taking care of a patient on the floor. In the old days when we had a rejection episode of almost 40 to 50%. So when I started out in the that's my age, when I started out in the 1980s as a surgical resident or fellow, we had rejection rates of 50%. And I can promise you, there was a very strong rumor, I don't know whether it's true or not, we felt that the lab people went down, had a cold beer, they had a coin, they flipped it, tails was positive, cross-match. We firmly believed that because of the incidence of rejection. But today, cross-match techniques have gotten much more sophisticated, and that's my, take-home message to you guys. We now have started pushing the envelope for living donors. And this makes me nervous, but this is what is happening across the country. I think we are still on the conservative side at MUSC, but you will see here, overarchingly, the donors above the age of 65, these do not go into children, these go into older patients. So we have spousal donations. A 65-year-old, spouse wants to donate to her partner, perfectly acceptable if both parties agree and they have no other medical issues. But the vast majority of donors tend to be in the younger age group. Some larger programs of national reputation, like the Mayo Clinic, have started pushing the envelope in single drug hypertensives, morbidly obese patients for living donors. And so the living donor safety outcomes have become a little more controversial than what I've shown you before. I told you I was going to switch and introduce you to a new concept. This again does not apply so much for the pediatric population, but again at the national level, we have started shifting in terms of estimating the donor risk on the cadaver donor pool. So the KDRI is an estimate of a relative risk of post-transplant kidney failure compared to the median donor. The lower the value, the less the risk of failure in the post-transplant period. So a whole bunch of risk factors go into this: age, BMI, your height, weight, your ethnicity, whether you're African American or white, the donor history of hypertension, diabetes, the cause of death, whether it was a trauma, whether it was a stroke, obviously the serum creatinine in the donor, the hepatitis or virus or serologies, and finally, you can do donors which is called circulatory death. So these are patients who are not brain dead, but you wait for the heart to stop, and they have a period of what's called warm ischemia. So the kidney has, no blood going to it for a few minutes before we take the kidney out. So this is a relatively, kind of a resurrection. So before brain death laws were in effect, the patients who were, quote, had no blood flow to the brain and were supported on a ventilator would be taken off the ventilator before the organs were procured. Now, if a patient is not completely brain dead and the family agrees to withdraw support, you can still withdraw support, and if their heart stops and they go into circulatory arrest, and then you could still take their organs out and utilize them. And so that creates an extra layer of risk in terms of kidney transplant outcomes. So the vast majority of donors have a low KDRI, and this is the group that we consider for the pediatric patients. But for our older population, we can push the envelope. So if I have a 65-year-old diabetic on the waiting list, I can take a high KDRI patient, donor, and that kidney may only last about 6-7 years, but that's, should be, maybe sufficient for that particular recipient. But for a pediatric population, we completely err on the side of utilizing younger donors, less than 50 years of age, no social risk factors, no history of any of the diabetes, hypertension, and so forth. Now, many of you may not know this guy, Alvin Roth. I didn't know him either. I know nothing about cooperative game theory. I know nothing about Shapley's theoretical, results, etc. But he had a great impact on my life and on your life that you may not realize. He was one of the brains behind the National Residency Matching Program. And I don't think he won the Nobel laureate for that reason. But he started creating this emphasis on what's called paired donor exchange. So frequently, we have approximately 15-20% of patients who have living donors, but using the old algorithm of histocompatibility or blood type, they do not qualify to be living donors, or they cannot donate to the loved ones. So what if we have a paired exchange? And that paired exchange can be done between individual families, but now we have gone to a national exchange. So you have national swaps. Some of you may remember one of the patients, and I'll show her x-ray, which I'm sure you'll remember, Anna Hatcher, whose stepdad wanted to donate to her. And this was in the Columbia State News a couple of weeks ago, because he's a major sports reporter in Columbia. So stepdad wanted to donate, and he was cross-match positive. He decided to go in the donor exchange pool. So we took his kidney out. His kidney was flown to Seattle. The Seattle donor, that kidney was flown to San Francisco. The San Francisco kidney was flown to Richmond, Virginia. And we got a kidney from Richmond, Virginia for Anna. So everything happens on the same day. Now, Dr. Tecklenburg is laughing at me. Transplant surgeons are crazy, but it works. And in fact, it is beautiful. All these kidneys have, technology is great. We have a GPS on the kidneys as they fly out. And every 15 minutes, you get an update of where the kidney is located. So you know where the kidney is, you know where the kidney is landed, so you always have the eye on the kidney. So, but these kind of national swaps have created a major impact on living donation. So you're taking away one more barrier towards living donation. Currently, there's some other works which are coming, which at the National Society is working on to kind of come across with substituting wages for living donors, trying to take away some financial barriers, etc. But from an immunological or logistic standpoint, this should happen. So this was Anna's X-ray, and if any of you, if you see that vertebral column, you could, clearly cannot forget this. So in children, depending upon their size, it can have some surgical challenges, as we did in her situation and some of the smaller children. And we go directly to the main blood vessels, to the aorta and vena cava. And we always put an adult kidney into a child. Pediatric kidneys into pediatric recipients is a poor idea, because these are small kidneys, small blood vessels, much more prone to thrombosis. And if you have a rejection episode in a small kidney with such small amount of tissue, you lose a kidney. So we always place an adult kidney into a child, and that can also have an impact because you could have a compression on the diaphragm. These patients may need to be, on a respirator or ventilator for a couple of days. They adjust fairly rapidly. This creates challenges in the OR in terms of hemodynamics. The new kidney sucks up about a couple hundred cc's of blood, which is a huge amount if you take a child who's 10 kilograms, and so forth. In the older children, we go lower down like we do in the adults. We do a retroperitoneal incision and suture it to the iliac vessels. We make a new connection to the bladder, and we frequently place a ureteral stent to protect us from leaks. Not infrequently, and I would say more common in children, we do native nephrectomies for FSGS, Wilms tumors, obviously for, obstructive uropathy with recurrent pyelonephritis, and not infrequently to create space for a new kidney. So these are some of the, differences that we have between the adults and the children of, going to intra-abdominal and going to the aorta and not infrequently, taking the native kidney out. Like I alluded earlier, the urology part and the bladder connection becomes a huge impact, huge impact on kidney transplant, particularly in the obstructive uropathy or the neurogenic bladder, where patients have vesicostomies. They have to be compliant with their self-catheterizations if they have a non-compliant bladder, etc. So these are some of the surgical considerations where you cross-clamp the aorta, cross-clamp your vena cava, and when you get ready to reperfuse, you get hypotensive. We frequently make sure the anesthesia is in the room. Not infrequently, the patients receive a blood transfusion with albumin or actual packed RBCs for the increased blood volume. The impact on lung volume and post-operative fluid replacement, again, becomes challenging. Monitoring for rejection becomes challenging because you put an adult kidney into a child, you're not going to have a classical increase in your creatinine. So in any of us, if we have a kidney transplant in an adult population, you look for an increase in creatinine. In the pediatrics, if you have an adult kidney in a 10-kilogram baby, you may just end up with fever spikes, and you may not perceive that as a rejection episode. So you have to have a pretty significant suspicion for rejection. Our immunosuppressive regimen has completely changed over the last decade. Cyclosporin has basically become historic, and tacrolimus is the mainstay of our immunosuppressive regimen. It blocks IL-2 synthesis and prevents T cell proliferation, and that's the main pathway. Azathioprine, or the old drug Imuran, again has become of historic interest, and the new drug is mycophenolate mofetil, which blocks, it's a very specific pathway of blocking purine synthesis of IMP dehydrogenase. It's a new class of drugs. There's a tremendous amount of enthusiasm of mTORs or rapamycin or everolimus. The advantage of these drugs was they don't have the nephrotoxicity that calcineurin has. So there was a tremendous enthusiasm to try to use mTOR inhibitors. Unfortunately, that did not plan out. So most centers utilize that only in a handful of patients, but it's not become the mainstream. Steroids have been the mainstream of transplant for the last 50 years, but as you can see, several programs, currently if you look at the registry data, almost 40% of programs today are steroid-free. The data here is controversial. The early data is suggestive that this may be okay, but the long-term data is kind of a big question mark, and there's a lot of concern that in the long term, steroid withdrawal may not be a good idea. I think all of us are familiar with steroid side effects on diabetes, hypertension, weight gain, etc. So I would suggest that we've minimized our steroid dose, but steroid withdrawal is being practiced across many centers around the country. I'm going to skip the intraoperative induction agents. So as I alluded earlier, in the old days, the focus was rejection, rejection, and rejection, which had an incidence of 50%. And today, rejection, incidence is in the single digits. And again, going back to what I was suggesting is our HLA techniques, the newer anti-rejection medications, our ability to understand what levels and how soon and how to manage these patients have all created this significant impact on reducing the emphasis on acute rejection. So again, still among patients and the general population, the first question I'm always asked is, is the kidney okay? Is it rejecting? But our emphasis on transplant has decreased. On the other hand, we start worrying about other issues, diabetes. As you can see, the incidence in adult population is skyrocketing. New onset diabetes approximately makes about 20 to 25% of this. In the pediatric population, again, this is becoming a growing incidence, particularly in our teenagers, some of whom are much bigger than me. A major concern in the pediatric population is PTLD. As you can see, the incidence is much higher in the children, particularly with the type of induction agents that you use. So we have to be very careful of T-cell depleting agents such as thymoglobulin. So we use IL-2 receptor blockade in many of our patients. Try to avoid multiple treatments of rejection. You have to be cognizant of the total global dose of immunosuppression in these patients. But the incidence is much higher in the liver transplant and the multivisceral transplants. But in the pediatric kidney population, it's still a significant incidence, about 1 to 1.5%. And finally, coming to outcomes of patient and graft survival, this is an old slide from the 2004 data. I was trying to find some recent registry data on pediatric population, and really, I think NAPROTIX has not kept up. That's the North American Pediatric Renal Transplant Collaborative Study. And unfortunately, they have not kept up with their outcome results. So I only have some old results to show, but I think it very much reflects the 2014 results. And my point here is, unfortunately, I tell my patients kidney transplants are like cars. After about 10 to 12 years, you probably have to look for a new car. So something like that, depending on the type of kidney you get, if you have a cadaver kidney, after 14 years, you're in time to get a new one. If you have a living donor transplant, after 20 years, it's time for you to get a new one. So that's the current, state of the, kidney transplantation. We still have a huge problem with long-term graft survival in our patient population. How much of this is driven by non-compliance? And in this group, the worst outcome is in the children, and I don't have a slide to show that, but the population between 6 to 17 has the worst long-term outcome other than my group beyond the age of 65. So that was my earlier comment, whether teenagers should have a preemptive transplant, because they truly do not appreciate, and it's absolutely heartbreaking to see a living donor transplant being blown away by a teenager who did not take his medications, goes to high school, college, gets that independence, and that kidney is gone. What are the results at MUSC? And this is what I think Dr. Twomley and I are most proud of. And I think it's small numbers, but this has been the trend at least for the last decade. There are very few programs across the country which can boast 100% patient survival and 100% graft survival throughout at least in the history of the program. And that's been the history, at least on the pediatric kidney side, for the last 10 to 15 years of our program. And clearly this is a team effort. It's just not the surgeons doing their job, but as you know, the post-operative management is critical. So finally, leaving you with some future thoughts. So where is kidney transplant going to go? It seems kind of, it's fairly common. This is what we do and we've done for the last 50 years. But where is it going to go? I think on the surgical side, we're looking at newer approaches. But how much of this is going to be applicable to the pediatric side, I'm not sure. Of robotic implantation, laparoscopic, I clearly see, this being a fairly prominent application in a high BMI, adult population, but maybe in a high BMI teenagers, this may be applicable. Suppressive strategies, as I've shown you earlier, has changed from cyclosporin to tacrolimus, and again, moving further and further, because we have a drug, calcineurin tacrolimus, which causes fibrosis of your kidney. It prevents rejection, but causes fibrosis of the kidney. It's such ironic, for the drug to be, that's most commonly used to be the most nephrotoxic drug in our regimen. So clearly, I think in the future, we're hoping that we'll have a much more stable calcineurin-free regimen. I'd briefly mention to you steroid-free regimen. There are some very exciting trials going on in Europe, such as infusion of Tregs to improve your immunosuppression. And we have one of my junior faculty members here, Satish Nadig, is did most of the groundwork when he got his PhD with at Oxford with Catherine Wood. He had the lead paper in Nature Medicine and Science. He did a lot of the groundwork on Tregs. Immune monitoring, we still the gold standard is a kidney biopsy, an invasive test. We have to get them sedated, put a needle into the kidney, and there are newer techniques which are appealing but have not become the standard of care, utilizing genomics, proteomics, etc. And finally, I think there is hope of regenerative medicine changing the field. I don't know whether in my time I'll see a whole kidney grown in a basin, but I think utilizing kidney cells to prolong graft survival, or utilizing kidney cells to prolong or extend your GFR or the life of your native kidney is something that we hopefully may see in the next 5 to 10 years. We have two people in our department, Mike Yost and Satish Nadig, working on this project right now, and hopefully we may have some exciting results in the next few years. So, kind of to conclude my talk here, there's some take-home messages. There's an increasing prevalence of end-stage renal disease overarchingly in the population. Kidney transplant is highly successful and economically viable. Patients require lifelong immunosuppression with decreasing rejection episode, but significant side effects such as diabetes and PTLD. And I feel that living donor and preemptive transplants, should be encouraged. Finally, I want to acknowledge my colleagues here. I think especially in my early days and continuing to today, the pediatric ICU group, Fred Tecklenburg, Joel Cochran, and Dave Habib require, a very special mention. And currently, what Dr. Twombly does for me in taking care of these children is simply, phenomenal. Makes my life so much easier. Again, thank you very much. I have a few minutes for questions, and once again, appreciate the time and the honor of giving the presentation. Thank you.